evening and good day, everyone. It's good to be back with Monica again. Hi, Monica. How are you feeling tonight?
Hi, good. How are you?
All good. Happy that you are back with us. If some of you don't already know, Monica Moore, she is actually right now, she is in Florida, US, and she is here with us tonight. And she will present a topic on fertility assessment for patients with PCOS. Okay. And I just want to mention that Monica is a founder of the Fertile Health, and she has been supporting patients throughout some years already, and she is also a nurse, right? Just remind me
Mhm.
that you are
Nurse
also a
practitioner.
nurse.
Yeah, yeah.
Exactly. So we are very definitely very happy that you are back with us and you have prepared your presentation. And of course, as always, we will start with the presentation, and afterward, it will be time for your questions. So remember, you can type them in the chat section during the presentation and afterwards, and Monica will answer them for you as always. And yeah, this is being recorded as well, okay? And already I would like to thank each and every one of you to join us tonight. It's a Friday evening for most of us, I guess. But of course, thank you so much for being with us, and I do believe it is going to be very very useful for you. And now I guess we can go ahead with the presentation. All right, Monica, ready to start?
Right. Yeah.
Excellent. Let's go.
So, hi everyone. I am a nurse practitioner. Oops, where did my slides go? Oh, there they go. Oh, perfect. Okay. And I'm a health coach, and so I work a lot with people who have hormonal disorders. And I always share when I do a talk on PCOS that I actually also have PCOS. So I have a personal and professional interest. It's this topic I'm passionate about. When I was offered a list of topics to speak on, I quickly jumped on this one. So I really hope to give you information. I hope to dispel maybe some myths that you've heard about this. I quickly peeked into some chat rooms on PCOS on Facebook and other platforms just to see the questions that people were asking so that I could address them proactively. But I really hope that everyone feels comfortable asking me questions as we go so that I can answer your specific ones. So there's so many facets of PCOS, but today we're particularly talking about the fertility assessment for patients with it. And so I really want to go over what is PCOS, which stands for Polycystic Ovarian Syndrome. How do you diagnose it? What does it mean in terms of fertility, which I think is really important? And importantly, how do you manage it? And notice I didn't say treat it, cure it, reverse it. We're going to talk about that. So let me just move my picture here a little bit. Okay. So PCOS, I want to let everyone know, is incredibly common. It actually affects between 6 and 10% of women everywhere. And some countries actually have a higher prevalence of it. So many people think it's closer to 10%. So really, really common. We see this in infertility centers all the time. There's not a day that goes by that I don't see someone who has PCOS or discuss PCOS. So I mention that because I think that when people are newly diagnosed with this, they feel so alone. They don't feel like this is, something common or something that they can share with people. So I mention it because I do hope that you realize that you are in a part of a much larger group of people that have this and, like me, have had to deal with it. It begins as early as a woman's first period. So commonly what we hear with women with PCOS is they get their first period called menarche, and then they really never have regular menstrual cycles most of the time. When menarche occurs, a lot of times you will allow a year to go by of irregular menstrual cycles for teenagers, women, before you say that that person has ovulatory dysfunction. But women with PCOS really never have a true period. So they're not sure when their period's coming. It is often maybe just 3 or 4 times a year. It can be very heavy because of its infrequency, which can be very difficult to deal with, control, And then when we get to the fertility aspect, very difficult to time relations because you're never sure when you ovulate. It is an endocrine and metabolic disorder. So in terms of endocrine, there are skewed hormones, not just the reproductive hormones that we're going to talk about, but the hunger and satiety hormones are skewed. And it is a metabolic disorder because it is associated with insulin resistance, which is very prevalent in probably most of the diseases that we know, just not just reproductive diseases. So it really affects more than just the reproductive system. When you go see a physician and you're diagnosed with PCOS or clinician, we have to talk to you about the aspects of insulin resistance, not just the fertility or reproductive system aspects. So let's start with what PCOS is not. And I actually see this advertised, in my opinion, incorrectly. It is not reversible. So you can have the disease and manage it, and it can be under the radar, but it is always there. You can eat and act and do things in a certain way, which we'll discuss, that will keep the symptoms underwater, so to speak. But doesn't mean that you don't have it or that you've got rid of it, which gets to the next. It's not preventable or curable, but it is incredibly manageable. You may feel when you're diagnosed very overwhelmed with the complexities of this disease and how far-reaching the consequences can be. So I do want to tell you that it's manageable, but if someone tells you that they are curing it or that it was preventable, that information is not supported in the literature. And is not confirmed by just one blood test. As you're going to see when we talk about the diagnosis, even though there are diagnostic criteria for PCOS, we usually follow the Rotterdam criteria, where you have to meet 2 out of 3 of those. There's no simple blood test that you can get that says you have this. So what we do is we have a suspicion, what we call a clinical suspicion of it, based on your medical history, what we see by ultrasound, and some blood tests. But we also have to rule out other conditions that can cause the same set of symptoms. So again, if somebody says we're going to give you a blood test, and when you get that one blood test result back, they say you have PCOS, that is also not supported in the literature. In terms of genetics, there's no specific cause for PCOS. There's no specific mode of inheritance. So we can't say because your dad is a carrier and your mom has PCOS, you have this % chance of having it. But we do know that the more family members that have it, the greater the likelihood is that you'll suffer either from it or potentially from insulin resistance. So we call that a familial clustering. That means that you're more prone to have it if you have a family member, particularly more than one family member that has it. And what we think here is it's a complex, what we call interplay between the genes and the environment. So there's something that you have a genetic predisposition to have this, and then something triggers this to go off in terms of consequences. And what we think for many people, at least for 2/3 of people, is it's excess weight. It's being in a higher BMI category. So let's talk about what happens actually when you have PCOS, because I think it's important to know that before we can really get to the diagnosis of it. Like, what does it mean to have it? What happens in your body? And these words are really difficult to see, but what I want to describe to you is if this is a normal ovary over here with one dominant follicle and a bunch of little follicles that never continue to grow, that one dominant follicle will mature, then it will ovulate, and that ovulation then will cause progesterone to be in your system. And if you don't get pregnant, that will cause a menstrual cycle. With women with PCOS, they have many follicles that stay in a resting state. So they can each make a low level of estrogen, but that estrogen level never gets to that peak, which triggers the LH surge, which triggers ovulation. So a blood test for someone with PCOS would reflect maybe a little bit higher estrogen, but never high enough estrogen to cause a trigger, often not high enough. If women with PCOS ovulate, it usually is 3 to 4 times a year. And we call that oligoovulation, so infrequent ovulation, or oligomenorrhea, infrequent menstrual cycles. So what causes the ovaries to do this? What causes this ovarian environment? This ovarian environment that's detrimental to follicular formation is actually called an androgenic ovarian environment, which means a prevalence of male hormones or androgens. Now, women we think of in terms of estrogen, we also do have male hormones, maybe 2% or so. And in women with PCOS, they're just a little bit higher, but that slightly higher androgenic environment in the ovary causes the ovary to look like this. So often, because the follicles accumulate, they get big and the ovary will be bigger. But I also want to talk about the word cyst in polycystic because it's a little confusing. A follicle is a fluid-filled sac that holds an egg. And we all, as women, have follicles, and they are all different sizes. But we think of cyst, I think we think that a cyst is something wrong. And the word polycystic was coined in the 1930s because there were many of these circles, but really they're just follicles. They're not cysts in terms of this is something wrong with your ovary. They are follicles that never end up maturing and ovulate, so they just kind of sit there in that state. So increased androgen production, which is what these tiny words say, inhibits follicular development and prevents ovulation. Well, what causes the increased androgen production? Because that also ends up being an issue in our appearance. When we have PCOS, we get what's called androgenic symptoms that we'll talk about. And there's a couple of different things. One is that there's an excess in what's called LH or luteinizing hormone activity. So LH is normally produced, but when we have an excess of LH production, it acts on a cell in the ovary that produces androgens at a much higher rate than it should. The other sort of culprit with this excess androgen is insulin. So we'll talk about hyperinsulinemia, but excess insulin levels can cause or exacerbate these high androgen levels. So we can't really do anything about the LH activity part. That was the first part. But if we make somebody sensitive to insulin, maybe we can help with the insulin part that makes this whole clinical picture worse. So PCOS is associated with insulin resistance. And so we'll talk about what that is. There is a correlation, meaning that more women with PCOS are insulin resistant than their age-matched controls. And I'll show you a picture of that. So at my age, because I have PCOS, I am at greater risk for insulin resistance and then all of the effects of insulin resistance than someone who doesn't have PCOS at my same body weight, at my same age. So what is insulin resistance? In order to really fully explain it, we have to look at what normally happens. So I'm going to kind of accommodate you to this slide. So this red is a cell. Let's say it's a red blood cell. And there are receptors on the red blood cell for glucose, which is blood sugar, to get into the cell. And we need that to happen for two reasons. One is we need it out of the bloodstream because it's not meant to be there at large amounts, as we know from people who are diabetic. And we need it into the cell because the cell requires it for energy to just do basic metabolic processes. The key that allows the glucose to go into the cell is insulin. So when you have hyperinsulinemia, what happens is this cell is resistant to insulin. So there's still the receptors, and let's say the insulin is the key, it's still there, but the key is almost too big to fit into this hole, or there's a clog somewhere here. So the pancreas secretes more and more insulin in order to try to fix this situation. So it bombards the cells with it, but the cells are resistant to it. So now what we have are elevated insulin levels and elevated glucose levels that are outside the cell. And we see this by certain blood tests that we'll talk about. This hyperinsulinemia, so insulin resistance causes hyperinsulinemia. The cell resistant to insulin means that the pancreas kind of panics and puts out more insulin. The cell is still resistant to it, and it perpetuates itself. Over time, can cause lots of different conditions. It can cause cardiac conditions, inflammation. One of the most common conditions that we know that it causes is diabetes, both type 2 diabetes and gestational diabetes, inflammation. Many researchers believe that insulin resistance is the basis for a lot of metabolic diseases, whether or not we can pinpoint that. Theoretically, they believe it's the case. So there's no cure for insulin resistance, But what we can do is try to make the cell or body more sensitive to insulin. And really, when we talk about any type of insulin resistance, but today for PCOS, that is our whole goal, is to help that person with lifestyle changes and or medications that make that person more sensitive to insulin. Then there are less risks for those metabolic consequences like gestational diabetes, but they also then have less androgens either produced or elevated because you don't have that insulin effect on those androgens. And remember, the androgens are what keep or help keep those follicles in that resting state. The androgens are also what produces some of the negative consequences or what we see with women with PCOS that can feel really disfiguring. So I mentioned to you that because I have PCOS, that my insulin resistance, the chance of it is greater than someone my same age with my same body weight. And that's true, which you can see in this picture. So a normal BMI between 18.5 and 24.9. When women have PCOS, there's a 10% chance of impaired glucose tolerance, which is the stage kind of before diabetes, or what we call pre-diabetes, and a 40% chance of insulin resistance and elevated androgens. So even that normal weight, we with PCOS still need to be very conscious that this condition is lurking. And I don't say that in a negative way. I say that in a way that when we go to eat and exercise, there are ways to combat this, that we need to keep this in mind. And this is why PCOS is not, or one of the evidence that PCOS is not reversible. So even a lean, quote unquote, PCOS person has this. Once somebody gains weight and gets into a larger BMI category, the prevalence of insulin resistance and hyperandrogenism goes up. So it went from 40% to 60%. 20 to 40% develop type 2 diabetes or impaired glucose tolerance by age 30. And 60% develop type 2 diabetes by age 50. And remember when I mentioned that it is a metabolic disease, and an endocrine disease, so it affects hormones. So we talked about insulin, but the other thing that it does, which really feels unfair, is it skews our hunger and satiety hormone. So the hormone that's supposed to be released when we're full or when the body perceives that we've eaten enough to have energy is called leptin. Just like there's an insulin resistance for some reason with this disease, there's a leptin resistance. So women who have PCOS feel hungry when they shouldn't and don't feel full when they should. And so if you have PCOS and you feel that way, it's real. There is actually an underlying physiology to that. There's ways to deal with and manage that in terms of honoring your hunger and the way that you eat. But that initial, I feel like I'm not full and I should be, feeling that you get is real. So I always try to, as somebody with PCOS and as a health coach, there are many conditions that we have or behaviors that we do that we wonder kind of why we do these things. And usually they are evolutionary adaptations. They are things that our body does to try to keep us, quote unquote, safe. So why would PCOS be helpful in any way? Well, when some insulin is a storage hormone, it stores fat. So in prehistoric days, when you went without food for long periods of time, those people who had elevated insulin levels could go longer between meals. And so you can imagine that that makes sense for people when meals are scarce, whether they have to hunt animals, they're hunter-gatherers. Those people with elevated insulins would not need to get a meal as quickly as those who don't. So then this ends up perpetuating this elevated insulin trait in people as an evolutionary adaptation. The problem that we have now is that food is plentiful, and processed food really can exacerbate these symptoms. So now we have excess insulin, which has a tendency to make us store fat. We have leptin resistance, which makes us never feel full. And then we have plentiful food, plentiful processed food for a lot of us. And so really this ends up becoming the perfect storm for excess weight. And in fact, 2/3 of women who have PCOS are overweight or have obesity. So how do we diagnose this? I was saying that there's no simple blood test. And the first thing we do is we talk to you. So have you ever had a normal menstrual cycle? Do you know when you have a menstrual cycle? Do you feel breast tenderness? Do you feel when you ovulate? With women with PCOS don't. It's just one day they suddenly have bleeding. That bleeding may be ovulatory, but more commonly it's anovulatory bleeding because the lining of the uterus has gotten so thick that it can't support itself anymore and it sheds. And that's why you don't feel ovulatory. And these menstrual cycle irregularities were their whole life. There's a differential diagnosis, meaning we're trying to figure out kind of what's going on. If somebody stops getting periods or has irregular periods after a certain event or after something happens and then we talk to them, that might be a different diagnosis. That may not be PCOS. Androgenic or male hormone symptoms. These can be alopecia, particularly androgenic alopecia, and that's hair loss, and often it's at the temples. So you might see women who have hair loss here. When I was reading a lot of the posts on the chat rooms of PCOS, a lot of people experience alopecia, it seems. So reducing your androgens can be really helpful in terms of relieving those, but hair growth takes many months to come back, and a lot of the anti-androgens you can't use when you're attempting pregnancy. Acne, and then body hair growth. This can also be really disfiguring because this body hair can be androgenic in nature, coarse, dark. It can occur in places like the sideburns, the chest, down the top of the thighs, the back, the belly. So, imagine if you are in your teens, you're a teen girl, and you have these androgenic symptoms. Maybe you have belly fat because that's what happens with insulin, acne. A lot of times you'd feel really bad about yourself. And in fact, the quality of life in people with PCOS who kind of haven't figured out how to manage it, you're more at risk for anxiety and depression. We do a physical exam. You don't need to be overweight or in a higher BMI category in order to be diagnosed with PCOS, but remember those symptoms can increase in intensity as your BMI increases. Sometimes we see, but not always, signs of what's called insulin excess. And the big word for that is acanthosis nigricans, and it's kind of brown looking in the folds of skin in the back of the neck under the armpits. And then by ultrasound, what we would see are PCO appearing ovaries. So before I showed you the actual kind of picture of a PCO ovary, a little bit bigger in size. Most ovaries are about 2 by 3 centimeters. This would be a little bit bigger. Those ovary, there's so many follicles that they kind of get squished in there, what we call compression effect. So they make the ovarian outside a little bit tougher, and they make the ovary size a little bit bigger. Just a little aside, many teenagers already have active ovaries like this. So if somebody has active ovaries and they're a teen, we're not going to diagnose them with PCOS. They need to have some other criteria, which we'll talk about. So there are other diseases that can cause ovulatory dysfunction or not getting a period. Anytime somebody comes to an infertility center without a period, we always do a pregnancy. So that's the first thing. Thyroid levels that are off or prolactin levels that are off can cause ovulatory dysfunction. In some women who have low body fat or who have had eating disorders, that shuts down part of the brain called the hypothalamus. That can cause ovulatory dysfunction. So we need to make sure that none of these particular things are going on by doing blood tests, these conditions. There's also a bunch of conditions that can cause ovulatory dysfunction with hirsutism, which is the fancy name for abnormal hair growth. So we always will double check androgens, because if you have androgens like DHEAS, 17-OHP, I don't know if you've heard these names before, and a free testosterone that are very elevated, they can be mildly elevated with PCOS, but very elevated, there might be something else going on that we would need to make sure that that's not happening with you. And then because these metabolic consequences, specifically insulin resistance, but also one of the biggest one of the biggest organs in the body that stores fat is the liver. And so we can sometimes see evidence of what we call non-alcoholic fatty liver, which with elevated liver enzymes in young people simply because of this tendency to store fat due to excess insulin levels. So we check for insulin resistance. We do blood work for that, liver and kidney function, and then we want to look at your lipids and cholesterol levels because they can be affected by this insulin resistance. In terms of checking you for insulin resistance, there's no really good outpatient tests. There's tests for when you're in the hospital, but obviously we don't want to hospitalize you just to test you for this. So we have a couple of options. One is to do a blood test called hemoglobin A1C, and that is a snapshot of how well your body processes blood sugar about 6 to 8 weeks ago. Another is fasting glucose and insulin, so nothing to eat or drink from the night before. And those are okay blood tests, but what they do is they're telling us that if they're abnormal, that something is already happening, that process has already started. We want to do a blood test that catches us at the earliest time possible, so it gives us more of a chance to not only detect this, but to help you manage it. And that is a 2-hour glucose tolerance test with insulins. So you do a fasting glucose and insulin, you drink a sugary drink, and then they test your blood for 2 hours afterwards. If any of those levels are elevated, then we're catching you early on in that hyperinsulinemia, impaired glucose tolerance, diabetes continuum. So that test catches you kind of at the early part of the continuum, whereas the other tests catch you a little bit later, even though they're more simple to do. So we always prefer a 2-hour glucose with insulin test if possible. So can I get pregnant with PCOS? I made the slide and I didn't write a bunch of words on it because I want to equivocally say, yes, you can. So here is the caveat with this. If you don't ovulate regularly, you're not getting a chance to get pregnant the months that you don't ovulate. You need to ovulate a follicle in order to have fertilization take place and to have implantation take place and to have pregnancy. So really women who don't ovulate regularly are not given a chance those months to get pregnant. Many of us in reproductive endocrinology don't even consider women with PCOS infertile or subfertile because the quality and quantity of the eggs that you have might be good. It's just that you're not ovulating them. So yes, it can be difficult to get pregnant on your own with PCOS. Do you remember that I told you that the LH stimulation in women with PCOS is stronger, the LH activity and activation? Ovulation predictor kits predict or test for LH and elevated estrogen levels. So women with PCOS may have false positive ovulation predictor kits. So now you have irregular menstrual cycles, so you never know when you ovulate because you don't feel it. So you try to do an ovulation predictor kit, and you can go through many kits that particular, if it takes you 3 months to ovulate, and then you may have all these false positives. So it's very, very difficult to time intercourse or relations when you have an ovulatory disorder. The good news is if we can get you to ovulate, hopefully using oral medications first, and precisely time your exposure to sperm, whether you're having intercourse, insemination, or you end up going to IVF, you have a really good chance, if PCOS is your only infertility factor, of achieving a pregnancy. Because really it's about timing, and it's difficult, if not impossible, to time when to have relations without using medications. If you're someone who is older and you have PCOS, that's a little bit trickier because your ovary looks very active, like the ovary that I showed you, and it is, but your age then correlates most with the quality of the eggs that we find. I want to go just answer a question in the chat because it is appropriate for this slide. And the question is, what oral medication can be taken to ovulate? So it used to be that we only use Clomid, clomiphene citrate, or Seraphine, I think it might be called in there. And that was the only FDA-approved medication for ovulation induction. And what Clomid does is it fools the brain into thinking estrogen is low. So then the brain puts out hormones that grow and mature follicles. Clomid is still the only FDA-approved medication for ovulation induction, but there's another medication called Femara or letrozole. It's in a class of medications that used to be used for women with breast cancer called aromatase inhibitors. And as of the US, I'm not sure in the UK, letrozole or Femara is the first line of oral medications for ovulation induction. So we try letrozole first and see if we can get you to make a mature follicle. And then we help you time relations, whether it's insemination or intercourse. So letrozole is first, called Femara, or then we can end up using Clomid if we need to. So often we can get people to ovulate with PCOS. Sometimes we need to go to something stronger in terms of the injections. And again, if someone's older and we get them to ovulate, the quality of the egg that they ovulate may not be as good, not because they have PCOS, but because of their age. And age is the one factor that is most closely associated with the quality of the eggs that you produce. So medications. So we give you medications both for ovulation induction, which we talked about. I'm sure that many of you know or have heard that we give injections for women who are going through fertility treatments. So if you can imagine, if you're young and you have a lot of follicles in your ovary that are just sitting there, that are kind of stuck or paused in that resting state, and we give you injections, which are very strong and powerful, that really we're putting you at risk for lots and lots of those follicles to mature and ovulate. And that's where we get into somebody having high order multiples, a pregnancy where more than twins, which we don't want to have. So if you end up having PCOS and having injections, really we're going to, for most people, recommend IVF because we have the ability to take the eggs that you make out, fertilize them outside the body, and then only put 1 to 2 embryos back. So you have a good chance of pregnancy and probably a good chance of having extra ones frozen, but we're not putting you at high risk for hyperstimulation. I also want to mention that that androgenic ovarian environment also makes you more sensitive to injectable medications. So not only do you have a lot of follicles that are sitting there waiting to go, but you have an ovary that's incredibly sensitive to these injections, and that can make you at high risk for high order multiples and something that we call ovarian hyperstimulation syndrome. So one of the most common medications, oral medications that can sensitize you to insulin is called metformin or glucophage. And we usually start off slowly with this, meaning give you maybe one either 500 or 750 microgram pill once a day. Always take it with food. I always tell people to start it in the evening because I know they've eaten by then. Maybe do that for a week. And if you can tolerate that, and by tolerate I mean not have really bad gastrointestinal symptoms, vomiting, diarrhea, just an upset stomach. If you still have those symptoms after 1 a day, then you stay on that 1 a day until you tolerate it before you go up to 2 a day. Eventually, many clinicians, or the high dose or the dose that we'd like to get you to, is 1,500. So that would be 2 of these 750s or 3 of the 500s. And the literature tells us that if we can get you to that, that is the best effect in terms of sensitizing you to insulin. Remember, once you're sensitized, that might help restore menstrual cycle cyclicity. It might help reduce some of those androgenic symptoms. But again, you can have these uncomfortable GI consequences. The other thing with metformin is it gets metabolized in the liver. So we always need to check your liver and kidney function tests before you take it, and usually every 6 months or a year while you're on it, just to make sure that they're not negatively affected by the metformin. Once you're on metformin, if you can tolerate it well, then often once you're pregnant, your obstetrician will keep you on metformin for the first trimester. Some people, obstetricians stop at 8 weeks, some 10, some 12. But what you can expect if you're on it is to stay on it, that you'd stay on it while you're pregnant. It's an FDA category pregnancy category B, which, there's nothing that we can say that's absolutely safe in pregnancy, but we do have a lot of experience with metformin in pregnancy. We don't always use metformin. So There are some clinicians that are more likely to give it. But what the literature shows is if you are not insulin resistant, meaning showing up on those blood tests, and then we give you metformin, we're not really helping you in any way. And again, metformin, like I told you, has some, pretty uncomfortable side effects. So the latest data is that if you have insulin resistance and is to offer you metformin, some clinicians will give you a 6-month trial of lifestyle changes. So working on weight loss, which we've already discussed is very difficult, increasing exercise. Skeletal muscle is one of the biggest, what we call uptakes, pulls glucose out of the bloodstream and into the muscle. One of the ways that we can get the glucose out of the bloodstream in terms of skeletal muscle. So exercise, even in the absence of weight loss, is one of the best insulin sensitizing strategies that we have. So if you're diagnosed with insulin resistance, some clinicians would go ahead and offer you the metformin. Other ones would say, let's see what happens in the next 3 to 6 months. And if you can make lifestyle changes, and that would positively affect your glucose and insulin markers, then that's worth a try. Neither one is wrong. It really is a center specific. What I found personally is, because when I work with people to try to lose weight with PCOS, if they really are doing everything that they need to do in terms of strategy, and the weight is they're really struggling with that because of these hormonal levels that are kind of all over the place, that the addition of metformin for some people can help. There are a couple supplements, though, that are starting to be studied. One is myo-inositol. It's a vitamin B complex derived product, so it's not a medicine, it's a supplement. And it also has insulin sensitizing agent properties. So there's been some small studies with myo-inositol, and there's starting to be more, that in PCOS patients, for some people, it was just as good as metformin. It improved cycle regularity. For some people, egg quality, reduced the incidence of gestational diabetes. Now you can see that this is a small study, and there's many more, but only in this particular study, 22 to 25 people had restored menstrual cycle after 6 months. So this is 2 things I'm going to say about myo-inositol. One is it's not often covered by insurance, so that you would pay this out of pocket, and you take it daily, and sometimes a couple of doses daily, depending on the myo-inositol that you have. The other thing is you really might not see improvement till after 6 months. This has been, many people, if they're on myo-inositol, will stay on it, again, for the first trimester of pregnancy. It hasn't been shown in the studies that we have to be harmful. We don't have as much data on it as we do with metformin in pregnancy because it's relatively newer. But the data that we have on it is really promising. And so if I'm working with someone who is not attempting pregnancy or who has a little bit of time to let this work, I always offer or tell them to go to get myo-inositol. You can find it often online. There's packets that you can put in a glass of water that you take twice a day that you can often get from a pharmacy, or you can ask your pharmacist to order for it. If your egg collection is within the 6 months, it's not too late for myo-inositol, but you may not get the full effect. So I don't think it would be bad to start it as long as you check with your specific clinician. I should say not all practices, even this hasn't been shown to be harmful. Some people might say, we don't usually use this. So you may not get the maximum benefit from it, but it shouldn't be harmful to start it a month before, even if you don't have that full 6 months to wait for it to work. Another promising supplement is called N-acetylcysteine, or NAC. They're actually using this for a lot of different reasons. I'm seeing it used for kids with ADD, and the way that we would use it is its insulin regulatory effects. Again, a supplement. In a prospective trial, meaning we give people medication, we study them ongoing instead of studying what happened to them already. That would be retrospective. So prospective studies are always kind of better in terms of evidence. They gave 100 women with PCOS randomly. So they just gave them a number, like you're going to be in the control group, you're going to be in the experimental group. And by randomizing people, what we're hoping is that we're making the control and experimental group very similar in terms of, their what they have in terms of their qualities. And if they have, like, the weights would kind of even out. We would have somebody in the experimental group and somebody in the control group that are relatively similar in terms of that. And then any what we call comorbidities. If somebody already has gestational diabetes, already has high cholesterol or fatty liver, that by randomizing, we're creating that in both of these groups. So in that particular study, NAC appeared to be comparable on hyperandrogenism, hyperinsulinemia, and menstrual cycle irregularity as metformin. Again, this is something that you'd have to take for a couple of months. It doesn't work right away. Most supplements kind of don't. Metformin might work quicker. But what I found personally with both NAC and myoinositol is that people don't get those symptoms, those GI symptoms that they do with metformin. And we don't see potential liver and kidney effects over time on the supplements as we do with metformin. Although metformin is a great medication and well known, it can be uncomfortable for some. So final thoughts. So PCOS is a lifelong disease, but it is manageable. We were talking kind of before we went live, and I have a whole bunch of slides that have to do with kind of what to do in terms of exercise and nutrition. Unfortunately, that would be another 45-minute to an hour talk, which I'm happy to do at some point. But it is manageable. And I myself struggled with weight issues, particularly when I went to college, where I couldn't exercise as often as I wanted to. I wasn't even sure what PCOS was. I had high carb or a very carb heavy meal plan. And I just found the weight was increasing, and it was even more frustrating as it wasn't happening to my roommates who didn't have PCOS, which, like I said, made me very frustrated. So it is manageable, but it is lifelong. So you have to keep in the back of your mind that regardless of your age, that you have this tendency toward insulin resistance, which can lead to other things. So if you manage it, great. And if you don't manage it, you really need to keep in mind and you need to get your tests done on a regular basis in terms of cholesterol, liver function tests, insulin testing, insulin resistance testing. We would love to catch you early before you end up becoming, let's say, diabetic, so that there's lots of different options that maybe we can either prevent or delay that. Insulin resistance is a core component of the negative consequences of PCOS. So the strategies that I mentioned to improve insulin sensitivity can really help. And lifestyle interventions, eating a certain way in terms of prioritizing protein at every meal, really trying to get yourself to the lowest sustainable BMI category you can, and really exercise. Strength training and cardio can make a big difference because of their effect on the muscle. You can get pregnant with PCOS. Whenever I read in the chat rooms, people that are asking, are saying, I don't think I'm going to be able to get pregnant with it. I really, really want to assure you that you can. But getting pregnant on your own without help with timing is very difficult. But once we are able to help you with the timing or help you ovulate, pregnancy should be achievable. You just may need to use medications to get there. So that's all the slides I have. Do you want to open? I've been kind of answering a couple of the Q&As as I saw them, but the longer ones I wasn't able to read, so I'm happy to answer those now.
And wonderful. Thank you so much indeed, Monica, for your excellent presentation and, of course, for thorough explanation, everything that on PCOS. But also, as you mentioned, if anyone would like to just get some more details on that lifestyle options you mentioned, it is definitely possible. You can get in touch with Monica directly. Yes, she is very right. We could spend another hour on that, I'm sure. So
Yeah.
thanks a lot. All right. Yeah, let's have a look at some of the questions that we've got here. And let's start with a very interesting first question, the longer one you mentioned. Just a second. Let me just show it to everyone right here. I was diagnosed once with PCOS and was given metformin to cure it. Since that time, my IVF attempts failed, hence using surrogate. I've asked my many doctors after that time if I have it now, and not one has said yes. None of them have seen it. Does that mean that I might still have it? And does this disappear after menopause? What should I do now if no one can see it, but you mentioned it's not curable?
Well, I'm wondering what they're looking for in terms of seeing. My guess is that they're doing an ultrasound of your ovary, or noticing maybe if you're in menopause, your FSH and LH levels are elevated, and we don't see that with PCOS. I think what's happening is a combination of things for you. There's some diminished ovarian reserve, and that's a fancy word for a reduce in the quality and or quantity of the follicles that you have remaining. So if they are saying that you're menopausal, or that was their term, I think that's probably what's happening. Some women with, if you were diagnosed with PCOS using the criteria that we discussed, so it's a true diagnosis, and they ruled out all the other conditions that can cause the same effects, then you have to assume as PCOS that you still have this propensity toward insulin resistance. So it's not curable, but it still means, in my opinion, to be careful with the way that you're eating and to consider the exercise. First of all, it's just a good way to live, but it can prevent or delay other conditions that can, affect your quality of life later. I'm not sure if I answered that question because it's a little complex and nuanced, but if I didn't, let me know.
Of course, thank you so much indeed for that. And while we are on that, have you ever heard that actually PCOS can be quite often overdiagnosed?
Well, it's overdiagnosed for sure in teenagers and in young women because people look at these ovaries, and you only need to have one ovary, like that ultrasound picture that I showed you. It doesn't need to be both, but both, of course, is obvious. But many young, healthy women have that. So that ultrasound picture in itself is not diagnostic.
Yeah.
Really, in order to sort of underscore this diagnosis, there has to be some sort of ovulatory dysfunction. It's very, very rare for someone with PCOS to have hyperandrogenism and polycystic ovaries and not have ovulatory dysfunction. So the typical scenario is somebody doesn't get regular cycles or doesn't get cycles at all. They come in, we do an ultrasound, we see PCOS appearing ovaries or PCOS ovarian morphology, which is the other name. Then we draw their blood and we see elevated androgens, but we don't even need to see them because if they have that ultrasound that shows very active ovary, often enlarged, with irregular cycles, PCOS is sort of that's where we're thinking that's happening. But there's a couple other conditions that can also be that we have to make sure is not going on, like the hypothalamic amenorrhea people I mentioned, people who are very rigorous exercisers. They have very active ovaries. It's just that they're not making their own FSH and LH to stimulate the follicles. So there can be some confusion in terms of a lean PCOS patient and a very kind of rigorous exercise hypothalamic amenorrhea patient. You have to be careful.
All right. Excellent. Thank you so much for that. I just heard that before, actually, and therefore that's my additional question. Perfect. Thank you so much. Okay, and let's have a look at the next question that we've got. Okay, so you have mentioned this during your presentation as well, but can you add anything? What is the prognosis for PCOS patients for IVF with ONEX outcome? I'm 36 already, and I'm worried more and more.
So PCOS really affects the quantity of eggs or follicles that you have. The biggest correlation between the quality is age. In keeping with that, 36 is not bad in terms of what's going on with fertility, of course. Over 35, there's a little bit of a difference. But if you get certain blood work and ultrasound done to look at or diagnose your ovarian reserve at age 36, and your FSH and LH levels are normal, your AMH level is normal, and you have active ovaries, which I'm assuming you do with PCOS, then you should have a pretty good chance with IVF with your own eggs. The challenge comes if you're 36 with active ovaries and we find an elevated FSH, we find a low AMH. Then the concern is, yes, you have lots of follicles, but we're a little bit worried about the quality of them. The good news is if you have lots of follicles and you do IVF, we have lots of choices. We have lots of choices in terms of what that egg and that quality of the egg, because there's so many follicles. When people don't have a lot of follicles and they have poor quality, we just kind of have to go with what that person has or presents with that much. So PCOS, like I said, at least we're getting a lot of follicles or hopefully eggs at retrieval. But then we need to really, determine the quality. And so we can look at them under the microscope for quality, and then we can also do genetic testing on them. Because as we know, really kind of pretty follicles pretty embryos or blastocysts under the microscope can be genetically abnormal, have an abnormal number of chromosomes. So if you are worried at all and your ovarian testing is normal or ovarian testing is a little bit concerning, you might want to combine the IVF, if you can afford it, with the genetic testing so that we're only transferring back genetically normal embryos. And that's not 100% chance of pregnancy, but it greatly will increase the chance of pregnancy and also reduce the chance of pregnancy loss due to something we call aneuploidy, or abnormal number of chromosomes.
Wonderful. Thank you so much indeed for yet another answer. Of course, your question. Okay, and there's a thanks from Angela from a previous patient,
My
and there's a
pleasure.
thanks also from Elle.
Yeah, my pleasure.
Okay, and you have answered Daryl's question, of course, on medication and metformin also. I guess, yes. And Maria also, this one was answered already. But Maria has added one more question, so let's have a look at this. So, should everyone with PCOS be careful with carbs or just some people?
That's a great question. The other myth with PCOS is that you have to be on a low or no carb or keto diet, which I always like to address. That is not the case. In fact, low carb or no carb diets may help initial weight loss, but they're very difficult to sustain. So often that weight comes back and can come back even more than before. So with that in mind, I think that anyone with insulin resistance, whether you have PCOS or not, should be careful with carbs. And what I mean by careful is that you want to have what's called a slow carb, a carb that doesn't make your blood sugar spike, because when your blood sugar spikes, your insulin spikes. And then what happens is your blood sugar drops. Then you get shaky, super hungry, all those symptoms that we get with hypoglycemia. Then you reach for a carb because you're shaky or hungry, or orange juice or a cracker or a cookie, and the whole thing perpetuates itself. So the first thing in terms of careful with carbs is to make sure the carb that you have is a slow carb. So it's closest to its natural form as possible, which is usually not white. So brown rice, multi or whole grain pasta. Quinoa is a really good carb that also has protein in it. The other way to be careful with carbs to mitigate or temper that big spike is to always, always, always combine them with a protein. So in fact, for all of my clients and patients, whenever they have a snack or a meal, the first thing that goes on the plate is a protein, not a carb. You pick your protein, and there's lots of options. Then having a healthy fat, olive oil, avocado, nuts, nut butters, the yolk and eggs, cheese. That also can mitigate that quick spike of the carb. Then you can have the carb, but it should be a carb that's closest to its natural form as possible, that takes your body a long time to digest. So that is what I call the perfect plate. Now, I always recommend color on a plate, which is vegetables and fruit. Even though we're not kind of talking about this, if I'm talking about in terms of completeness for the plate, I would be remiss to not mention that it has to have some color. So never have a carb by itself. So always prepare, if you go to work or you're at home, to have these staples in your house, nuts, nut butter, cheese, eggs. I always tell my clients to hard-boiled eggs, make a whole pot of quinoa, and always make sure that you're combining them. So if you have an apple, make sure you have it with a cheese stick. If you want to have a banana, make sure you have it with nut butter. That is the best advice that I think, and I think that that's in keeping that spike, not like this, but kind of a little bit more like this. You're also going to feel better during the day, and you're not going to have so many cravings.
Amazing. Thank you so much for yet another advice. And actually, when we are on that particular topic, let me go straight to this question from Amy. In terms of dietary requirements, is a sugar-free, dairy-free, Peanut butter free, sorry, okay, diet recommended for
Wouldn't it be
PCOS.
great if we had a peanut butter diet? Like all we could eat was peanut butter. It'd be awesome. It's not recommended. So a lot of, so you can be very strict. And I've seen people with anti-inflammatory diets, and by diet I mean way of eating, not restricting food, that would say no sugar, no alcohol, no dairy, no nuts, because these things in some people can be inflammatory. And anytime you have excess insulin, that's also an inflammatory process. If people are not sure how they respond to food, then what I tell people is to limit. I really haven't seen it with nuts to say, but to limit meat, alcohol, sugar, dairy, and then reintroduce it after like 3 weeks. So I've seen people do that. I don't personally recommend that because I haven't seen the support in the literature that says that's the case, and I find that it's very restrictive. And I don't want people to feel like they feel deprived when they eat. I want there to be common foods that you can eat without feeling like you have to not have the stuff. That being said, if you eat, I always tell people I want to desensitize them to sugar, because, and what that means is that I want them to get used to not having sugar. Usually it takes about 3 to 4 weeks, so that when you have sugar, it feels too sweet. So I tell people to go sugar-free, and I mean in terms of added sugar. If you have fruit and there's sugar in it, that doesn't count as far as I'm concerned. But in terms of added sugar, for about 3 to 4 weeks, so that you can get that sugar taste kind of, and that craving for sugar out of your system. But it's not necessarily because it helps with the PCOS. Of course, overdoing sugar can make things worse. I also prefer, I've got to say, like almond butter over peanut butter. And that's just a preference that I've heard with people for some reason, and it takes a little bit getting used to that taste. But for some reason that people have told me, like almond butter instead of peanut butter, so wherever you would use it, use the almond butter, doesn't seem to have that same allergic or uncomfortable effect, whether that's the stomach, whether that's you're hungry sooner. So I usually tell people to give almond butter kind of a try wherever they would use peanut butter and see how it goes. I find that most people, after the initial getting used to it, really like how it makes their body feel. And to me, that's the whole goal.
All right, amazing. Again, thank you so much for yet another question. Great question, and of course, your help with that. And there are like 3 questions left, so we will be slowly finishing. However, if you have anything else to add, you know what to do. Go ahead. Okay, and let's have a look at the next question. Thanks for wonderful presentation. I absolutely love the clarity with which you have presented this area to us. My question is, in what cases are surgical methods like ovarian drilling advised, and do they treat PCOS?
That's a great question. I actually had ovarian drilling done myself. Ovarian drilling is where, it sounds like an awful term, right? It's called diathermy or drilling, is where they do a laser and they go in through laparoscopy, so through the belly button in a small incision, and they laser the ovaries. And it makes these little kind of like brown dots. And so what they think is that it almost like, you know, when you see like in the movies where you like shock somebody's heart and it kind of gets it to reset, ovarian drilling might do that. So in women with ovarian drilling, it actually might restore menstrual cycle cyclicity without any medications. And it can improve that androgen or hormone profile. So it doesn't make it great, but it can be really helpful. In order to do ovarian drilling, though, you need to have a laparoscopy. And the other issue is you need to really understand that we're not sure by doing ovarian drilling if there's a potential for damaging the ovaries. So it's usually not a first line offering with people for that reason. But if you have, so I'm in the medical field, and I actually ended up being born with an issue with my uterus where I can't carry more than one baby. So it's very difficult to stimulate me with medications and keep that from happening unless I went to IVF. So because I understood the consequences of ovarian drilling and I needed a laparoscopy due to the ovarian issue, they consulted with me about this and I decided to have it done. So it's really good for people that need to have a laparoscopy, can really understand the potential consequences of it. But because the ovarian stimulating medications are so good and so prevalent, we usually end up going to use those as a first line as opposed to drilling.
And wonderful. Thank you so much, of course, for yet another great advice. Okay, thank you also for sharing. Yeah, let's have a look at the next question. Okay. I'm 45, active and not overweight, high MH. All doctors immediately say PCOS when they hear this. I have no other symptoms, monthly periods, even though not necessarily same cycle lengths. I would love to know for sure if I have PCOS. I have one doctor that mentioned PCOS, and all other doctors have said no, I don't have it. So I'm unsure and would like to obtain a confirmed diagnosis.
So I'm wondering why, if they think you have it, if it's just because of high MH or there was an ultrasound that showed really active ovaries. So my thought is that if you're 45 with active ovaries, and I'm not age shaming anyone, I'm actually over 45, but if you're 45 with active ovaries, they might be thinking that's so unusual that there could be PCOS or PCOS appearing ovaries. The issue is if you don't have elevated androgens, either when we examine you, acne, hair growth, hair loss, like I discussed, or when they draw your blood, if the blood androgens don't come back elevated, then you don't meet the criteria for PCOS. All you have are active ovaries because you don't have ovulatory dysfunction. If your periods are somewhere between 25 and 35 days, even if they're not always 25 or over 35, that's not considered ovulatory dysfunction. That's considered regular menstrual cycles. We always think 28 days, but very few women have regular 28-day cycles. They have to fall between 25 and 35 days. So to me, it just seems like you have an active ovary, but you don't meet necessarily the other conditions or criteria to diagnose you with PCOS. It sounds like also because you are in a good BMI category and because you're active, if you have insulin resistance, which is maybe the reason kind of that you want to know this, is do you have insulin resistance? You are doing lifestyle changes. You have, okay, so I see that you have acne. You're doing lifestyle changes that you would do for insulin resistance anyway. So I hope that's helpful. It's difficult. It's a very difficult diagnosis, like I said, to confirm. Some people it's very clear cut, but other people, like in your situation, but you wouldn't just have developed it usually at 45. You would probably have had it your whole life. Like I was explaining, like you never had regular cycles, really have issues, or many people have issues with weight. It wouldn't be that once you're 45 that you end up getting it. That would, I guess it could potentially happen, but that's not a common presentation for it.
All right, again, thank you so much. And I will go to the question from Aid here. Okay, so I am pre-diabetic. I can't lose weight despite eating healthy and moderate exercise. Could I have PCOS? And of course, she also added, I have acne.
You could. We're missing two criteria though: irregular menstrual cycles and polycystic appearing ovaries. So it sounds like you have insulin resistance if you're pre-diabetic, and I'm not sure if they diagnose that with the glucose and insulin test, hemoglobin A1C, or how they diagnosed you as being pre-diabetic. But it sounds like you have some form of insulin resistance, which is incredibly common. Insulin resistance both makes it difficult to makes it easy to gain weight, and then excess weight exacerbates insulin resistance, which is incredibly frustrating because it's kind of a vicious cycle. But I wouldn't say that you have PCOS unless you have at least one of those other two criteria that I mentioned. Ovulatory dysfunction to me is the biggest one. For me, people with PCOS, even though there's two other criteria, androgens and PCO appearing ovaries, or you're saying your menstrual cycle is irregular. So it's a possibility. So I don't know if do you have acne and menstrual cycle irregularity? So that's 2 out of the 3 criteria. I don't know if you had an ultrasound to see if PCO appearing ovaries, but you have insulin resistance. So it is possible. But what I would do is, since you have insulin resistance, it sounds like anyway, because you're pre-diabetic or you're in the impaired glucose tolerance part of the continuum, which is kind of the next step, that you should work on insulin sensitizing strategies. And they're hard. It's very difficult to lose weight. And And what works for other people in terms of healthy eating and losing weight doesn't always work for people with insulin resistance. So sometimes it comes down to, making your plate a certain way, really increasing strength training, not just cardio, because of that muscle hypertrophy with strength training that can really help. And if I don't know if they offered you metformin, but a myoinositol sounds like between the acne and the insulin resistance that might be helpful for you. And I think it's pretty commonly found in Europe, and not just, it might be called chloroinositol there instead of myoinositol.
Amazing again. Thank you so much indeed. And I will need to go back to the previous patient, okay? She has added some details, Daryl, okay? So this is the question, the first one, and this is possibly active ovaries, as I had lots of eggs when I completed IVF, although 3 failed attempts, and we have done PGT, seems to be equality. I'm just trying to eliminate other issues.
What was the first part of that question? I'm sorry. I know
Yes, of course. This is the question here. Unsure and would
so,
like to obtain a confirmed diagnosis.
okay. Okay, and then can I see the second part again? I'm sorry. Possibly, yeah. So you had lots of eggs when you completed IVF and then 3 failed attempts. I guess it's a possibility, but it does sound like to me it's egg quality. And unfortunately, when you're 45, that's the issue, is that so usually quantity and quality go together. When somebody's 45, we suspect poor egg quality, and we assume that there is not as much of a quantity. But in women with overactive ovaries, you can have a high quantity, but the quality is poor. And it sounds like that might be what's going on with you, with your cycles, unfortunately. So I don't know that knowing the diagnosis of PCOS for you for sure would be helpful for your IVF. I think it would be helpful for you to know for life in terms of how to manage the disease, but I don't know that it would help you in terms of giving you better outcomes on your subsequent cycles.
All right, thank you so much. And let me have a look, okay? More questions are coming up. Yes, and there's a thank you
You're
from
welcome.
our
You're
patient.
welcome. You're welcome. Pleasure.
Next question again, it's definitely interesting. So how can we prevent ovarian hyperstimulation syndrome when we do IVF to PCOS patients?
It's a great question. So we talked about the fact that you're at risk for ovarian hyperstimulation with IVF because you have a lot of follicles in a resting state, and you have an androgenic environment in the ovary, which makes you more sensitive to stimulating medications. So, and I love that you use the word prevent, because once somebody has OHSS, we can't fix it. We have to kind of manage it and take care of that person. So preventing is best option. So one thing is to start with lower doses of stimulating medications. You don't need the doses that somebody else your age that has PCOS probably don't need that. The other really good, well, there's 2 other options. Another good option is if you can use an antagonist in the cycle. In the States, it's ganirelix or cetrotide. I'm not sure what it is if you're in Europe, but an antagonist. Then it allows us to use a trigger shot, which is the shot that ovulates you, called Lupron or leuprolide acetate. What that does is it creates an LH surge, an ovulation surge, that doesn't last as long and is not so pronounced. And what we find is that and it allows us to use the trigger shot of HCG less of a dose. So what makes ovarian hyperstimulation worse or intensifies it or gives you more of a tendency to have it is a pregnancy hormone in your system, either because you're pregnant or because we gave you HCG to trigger you. So being on an antagonist to keep you from ovulating, starting you with a low dose of medication, and then giving you a combination of low HCG and that Lupron for trigger can really help. The other thing is again, if you're starting to, if there's a concern that you're hyperstimulating, we actually don't want to attempt pregnancy that cycle, because once you're pregnant, it can make it worse. So we would really want to freeze the embryos that cycle, let everything calm down, and then once that calms down, to give them back to you in a subsequent frozen embryo transfer cycle. If we don't attempt that month pregnancy for you, then we can give you a medication called Dostanex, which is a pill. We start you on it around the time of the retrieval. It's different percenters when they start. And that also can help prevent or temper the symptoms of ovarian hyperstimulation, but we can't give that to you if you're attempting pregnancy and having a fresh transfer that month.
All right. Again, thank you so much for yet another great question, as you've mentioned, and of course,
And these
for your
questions
advice.
are really good.
Yes, I couldn't agree more, really. And we are very happy that you are here and asking those questions, of course. And let's have a look. Maria has added one more question here. My last clinic said they detected PCOS. Do you think they could have seen that from the hormone test, or would it be the high number of eggs previously retrieved? As you can see, all the details right here as well.
Yeah, I'm assuming that these are done on day 3 of a period, or they're not just kind of randomly done. If that's not the case, let me know. But I'm going to assume that these are done day 3 of a period. So I would need to know, first of all, what your normal prolactin is, because you might be measuring in picomoles over there. We measure it in grams over here, so that prolactin level looks high. But if your prolactin and thyroid levels are normal, you think it was the correct day. Okay. So it is only valid to test someone's FSH, LH, and estradiol on day 2, 3, or 4 of a period. AMH, prolactin, and TSH can be done at any point. But the FSH, LH, and estradiol should be done day 2, 3, or 4. What is concerning to me is that estrogen level looks a little bit high depending on that lab. So that might make the FSH and LH levels lower because they have an opposite relationship. And we really need to know what those true FSH and LH levels are. So they may need to repeat the estradiol level to get it to the normal if that's not normal, so that we can really see what's going on. Many women with PCOS have an LH-FS ratio of 2 to 1. It's not necessary for diagnosis, but remember I said the LH effects or activity are usually stronger. So then what we would see with you would almost be a reverse in those. So the LH would be 6, maybe the FSH 1.8. So that sort of doesn't make me think that's going on. And the AMH of 2.9, I'm not sure of your age, but that's a regular normal AMH level in most labs. Over 4 puts people at risk. You just turned 41. Okay. Over 4 puts people at risk for hyperstimulation, and you're not there. So there's nothing here that's making me think that you have PCOS. It sounds like that you maybe just had active ovaries when they did your retrieval, but none of these labs without the, so you either need active ovaries, not ovulating, signs of androgen. Oh, so you had 34 eggs retrieved. So your situation is very similar to the woman or the person that we discussed earlier who's 45 and had a lot of eggs retrieved. But I'm not sure that you have those other symptoms. It's just that it's probably with that amount of eggs, they're assuming that it's PCOS, but usually you see some other thing going along with it. And it says you don't really have the other symptoms. So I just think, they're surprised at the number of follicles that they made at your age. And again, I don't mean that in a negative way. I mean that just like totally scientifically based. At 41, a lot of times people have trouble with just IVF because they may make 10 eggs, they may make 15 eggs. So 34 eggs might make them think that's what's going on. But I don't know that they would treat you any differently in an IVF cycle due to the fact that you could have PCOS. So I think it'd be helpful to know in terms of your life, but I don't know for IVF if they would do anything different unless you hyperstimulated that cycle, and then we need to treat you differently in a subsequent cycle so you didn't hyperstimulate.
All right. Again, thank you so much. And I love that this was like more of a conversation, really, with our
I do
patient.
too. I do too.
Wonderful. Thank you so much. Okay, let's have a look at.
I think there was a CoQ10 question.
Yes, right. Sorry. Yes, right here. Sorry,
Yeah,
I missed that,
that's
but it's
okay.
right. How much CoQ10 daily do you recommend for PCOS and about to start IVF? Is 600 milligrams, I guess, ideal?
So CoQ10 is a supplement, and just to give you some background on it, the machinery in the cytoplasm of every cell there's mitochondria. It's a structure in the cytoplasm of the cell. And the mitochondria's job is to produce the energy for cell division, which of course we want when we want pregnancy. Cell division is really hard work, meaning it takes a lot of energy. It takes a lot for the body to go under cell division. So the mitochondria really need to be pretty powerful in terms of being able to make this cell division go efficiently. So as eggs age, we always think of the chromosomes. The chromosomes can be abnormal, but the other thing that ages is the cytoplasm and the mitochondria in the cytoplasm. So if there's some kind of supplement that we can give that might strengthen mitochondria, that might be helpful. And CoQ10 is what they found that might be. So they did animal studies with CoQ10, actually the same facility where they kind of discovered the use of letrozole. And what they found in these animals was they had bigger litters, and they got pregnant quicker when they were on the CoQ10, because this is sort of like the spinach or kind of like special food for the mitochondria so that it can produce energy like it needs to. So I think CoQ10 is helpful just whenever you're doing IVF, whether or not you have PCOS, especially if you're a little bit older. But many centers I work with put everyone that's doing IVF on CoQ10 in order to help. In terms of the dose, it differs. So some people want, say, 300 twice a day. Some people say 300 3 times a day. But there's also a, gosh, what is the name of it? I think this is called like MyoQ10. I'm just not sure if it's in the States. I think it's 1 gram, but it's equivalent to the 600 to 900 of the CoQ10. So a lot of places will say 300 BID, which is twice a day. Others will say 3 times a day. I wouldn't kind of overdo the CoQ10 on purpose, but if you take it 3 times a day instead of twice a day, usually any excess is just secreted in the urine. It's not harmful to you. And then, like I said, the MyoQ10, I think what it's called is 1 gram, but whatever is equivalent to that 600 or 900, depending on what your clinic recommends. The studies have been done on both 600 and 900, but separate doses, not just taking that one, except for that special. Oh, it's called NeoQ10. I'm just gonna look at it real quick while I have you.
Sure. No problem. Let's have a look.
Yes, so it's made by this company called Theralogics. I do not have stock in Theralogics, but NeoQ10, it doesn't have, there's 90 in there. The reason that a lot of places, like, it doesn't look like it has any different, it just looks like that is what that dose is. Whenever you get NeoQ10, you're getting the dose. But what I think people like it is it has better, what's called bioavailability. It's absorbed better by the body than other CoQ10 supplements. So a lot of the fertility centers I work with recommend it, because then when you take this dose that you're getting, the medication that you need. It's not getting lost in the liver or the digestive system where we process this first. Is ubiquinol better than CoQ10? If so, what's the difference? Let me see what the dose is. This group is really on it. I feel like I'm so glad I have my computer here, because everybody here is
yes,
so knowledgeable. Okay, it is, let me see here what the dose is. It says that. Don't see, let me look at one other thing. Sometimes in the States, we use different medications because of the availability of them. Okay, let's see. Okay, hold on 1 second. Gosh, I have like all these pop-ups. Ubiquinol, I think it says. So this is saying, this sounds like for that the ubiquinol might be more what they call biologically active. So it's bypassing these organs that kind of use up all the medication. So that might be helpful because it's potent. But let me just see if it tells you what the dose is. Milligrams. Okay, so most people are using of the CoQ10 300 twice a day. I have seen people use 300 3 times a day, but most of them are using 300 twice a day. So let me see if this says what. Okay, let's see. It's 100 milligrams a day is the regular dose. And if you're older, you suspect decreased levels, then it's 200 to 300 milligrams a day for 2 weeks. So what some places might do is put you on 200, 300 for 2 weeks and then lower you back down to that maintenance dose of 100 a day. The problem with these supplements is they work best when you are deficient in them. But we can't really test to see if you're deficient in them. We don't, not like vitamin D when we know you're deficient. So what they might assume is if you're going through fertility treatments that you're deficient in it, that's an assumption. Then build up your stores of it by giving the 200 to 300 a day for 2 weeks, and then go back down to the 100 a day maintenance dose, because then the assumption is you're not deficient in it anymore. So we do that sometimes with CoQ10, and it sounds like this is what they recommend with the ubiquinol as well.
Amazing. Thank you so much for checking this as well.
Yeah, sure. You're
So
welcome.
thank you so much. And as you can see, there are many, many things coming up. And for now, at least,
Really my pleasure.
see that that was our final question. There was one comment from Angela. You might need to look at it. The Harvest Day Crunchy Almond Peanut Butter is great, by the way. No added sugar, but contains 2 grams naturally. Just so
That's
everyone
great.
knows.
Yeah, I look at the nut butters. I always recommend getting the natural ones. Now, some of them you have to stir because there's that. What makes them natural is that kind of like film on top. But some of them will say no stir. But we really want, like Angela's saying here, to get the natural butters, no matter what the nut butter is. So the regular kind of brands, like in America, like Jif, they're processed in order to keep it just looks better, to have everything in there without stirring. But in order to keep the shelf life, you have to have additives. So I always tell people get the natural and the not processed nut butters, and it's organic too. Awesome. The not processed nut butters, because there's less preservatives. So even though they don't look as good because you have to stir them, they're better for you for that same reason in terms of that spike of the carb. It takes longer to digest them because they're natural, as opposed to adding additives that makes them easier to digest, look good, and taste good, and then your blood sugar goes up.
All right, amazing. Again, thank you so much for that comment, Angela, as well, of course. Yeah, and for adding Monica as well. And we will be finishing for tonight. And as you can see, things are coming up. Great webinar. Really appreciate your help. Awesome presentation. Thanks. And what can I say?
My pleasure. It seems like there's a lot of interest, Caroline, on what you can do healthy
Yes.
food wise. So maybe later on in the series we could do like a specific talk on that, because that is
We are always open for any of those, because yes, it's a thing that always comes back. So thank you so much indeed. And yeah, well, Monica, as you know, we are in touch. So hopefully
yeah,
we will be able to just simply schedule another one. And we are definitely open and happy to be able to help you out and also have you as our presenter. That's for sure. Thank you so much, everyone, for joining us tonight, for all of your great questions,
yeah.
and Monica, for your excellent advice, and well, for spending this evening, but also, well, afternoon with us as well, wherever you are. And I can only wish you now a nice evening, but also a great weekend to everyone, and of course, great rest of the day for Monica and anyone that is in the US. Thank
Thank
you
you.
so much. Yes, Angela, I do see your comment here. Okay, there will be a session actually on that, Angela. Okay, it will take us a little bit longer, but there is something coming up on surrogacy as well. Okay, just so you know. Thank you so much, everyone. And again, Monica, it's been a pleasure as always. So I guess all I can say, in touch, okay?
My pleasure, and thanks so much for the interaction. It really makes it fun for me too to see the
Yes,
kinds of questions that you have. So we
we
appreciate it.
always we always love that. That's for sure. Thank you a lot and take care. Bye.
Bye bye.